The primary objective of this discussion today is to have a better understanding of the role of the injury management consultant. I believe the role is not well understood and definitely underutilized. It's been around since the initial introduction of the diagnostic protocols in Alberta. However, I venture to guess that not many physiotherapists are aware of its existence. I personally have to admit that I was aware of the IMC. However, I didn't understand what a valuable tool it could be until just recently. We are seeing an increase in scrutiny from the major MVA insurers, and possibly rightly so. An unfortunate trend is developing in physiotherapy, where we're seeing an increase in the duration of care and the cost of care, and unfortunately a decrease in successful outcomes. This trend is not being well received by the major motor vehicle insurance companies, and I believe we're on the cusp of seeing a significant pushback if these trends continue. The first slide in the presentation basically defines the role of the IMC from the DPTR. For those of you who are not familiar with the DPTR, it stands for the Diagnostic and Treatment Protocols Regulation, which was put forth by the Alberta government. And its goal was to ensure that people who were involved in motor vehicle collisions in Alberta receive fast and effective treatment for support of their recovery. I venture to guess that many of us have never read the DPTR, or if we have, it was many years ago that we consulted it. I would suggest that it's a very good resource to have a look at in terms of understanding the rights and responsibilities of the physiotherapists, the insurance companies, and the patients with regard to recovery from their motor vehicle accident injuries. I would further suggest that every clinic have a copy available for reference. Back to the definition of the IMC, an injury management consultant means a primary healthcare practitioner, could be a medical doctor, chiropractor, or in this case, physiotherapist, who is basically entered on the Injury Management Consultant Register. In order to get myself on the IMC register, I first had to apply with the College of Physiotherapists in Alberta. After reviewing my application and my training, they deemed that I was an appropriate candidate to become an IMC, and then they put my name forward to the Superintendent of Insurance. So now you can find myself as well as other IMCs registered on the Government of Alberta website, as indicated on the slide. Hopefully during the course of this talk it will become very clear that an IMC referral is much different than an IME, which is an independent medical examination. And hopefully with appropriate use and timing of an IMC referral, we'll be able to improve successful outcomes and decrease the amount of patients that end up having an IME. The DPTR suggests some reasons for IMC referral. A primary healthcare practitioner, which as we established includes medical doctors, physiotherapists, and chiropractors. Those individuals may refer a patient to an IMC if the primary healthcare practitioner is uncertain about the injury to which the DPTR apply, or the diagnosis or treatment of the injury, or they believe that the injury is not resolving appropriately or is not resolving within the time expected. So basically the IMC can act as a second opinion. I'm sure you all have many situations where you're trying to decide if it's a WAD 1 or a WAD 2, or a WAD 2 versus a WAD 3. Or is it a WAD versus a concussion or versus a vestibular issue? Is it a knee sprain or an internal derangement? Is it a WAD with referral to the shoulder, or is it a WAD injury and a primary shoulder injury? Another example would be WAD with referral to the jaw, or WAD plus a TMJ injury. It's very important that we get the diagnosis correct, as it can significantly impact the services and treatment available to the client. You might find that your treatment plan itself is unclear. The injuries are very complex and you have little experience dealing with them. The treatment's not helping and you're not sure what to do next. Do they need a type of treatment that you don't provide? IMS, manipulation? Are you struggling to identify flags that would indicate a delay in recovery, such as psychosocial issues? And should multidisciplinary care, potentially including OT and psych or other disciplines, be involved? These are precisely the types of questions and situations that an IMC can help to clarify. The DPTR also suggests a number of alerting factors that we also need to consider. If a patient is diagnosed with a WAD 1 or 2 injury, the patient has alerting characteristics that may influence the prognosis. The primary healthcare practitioner must, the language is very clear, they must seek to reassess the patient within 21 days of the collision. And if the injury is not resolving, a referral to an IMC for an assessment and report is indicated. Taking a look at the next slide, this is straight from the DPTR, and it's basically a flow chart of how you would manage a WAD 1 or a WAD 2 injury, or any other injury that qualifies them to be within protocol. So basically, after you initially assess the client, on the AB2, there's a section below the goals that indicates whether or not you intend to reassess the client within 3 weeks. So if you see alerting factors or are confused or unsure about what to do in terms of treatment or diagnosis, I would highly suggest that you check one, if not all of those boxes underneath the goals and indicate that that would be your intention. Some adjusters, just like physiotherapists, won't necessarily understand the IMC process. It's been around for a long time, but as I said, it's not been highly utilized. So we need to take the approach of educating them on how the IMC can help the management of their complex clients. If they are trying to block or deny your access or referral to an IMC, you can refer them to the DPTR. The next slide reviews the alerting factors as indicated in the DPTR. They may seem a bit odd on first glance, but they are based on validated research. Of course, I wouldn't say that if I had a client that was female or over the age of 40 alone would indicate that an IMC referral or reassessment is required. However, if you do see combinations of these factors, including high level of neck or back pain, very intense headache, presence of radicular symptoms, and other yellow flags, in combination with female gender and age over 40, the research suggests that these individuals may have a poor prognosis for recovery. There are a number of valuable outcome measures which I'll discuss in the presentation, which can help us also to determine whether or not this individual has alerting factors and can be used as objective measures in your referral. This next slide just goes over a number of different outcome measures that we can use and scores that might predict a poor outcome for our individuals we are treating. The next slide reviews the role of the IMC. The injury management consultant can provide advice, report on the diagnosis and treatment of the patient, recommend further assessment or multidisciplinary assessment of the injury, recommend diagnostic imaging. So I would have no interest in trying to take your clients or shuffle them to another clinic, and also to produce a report for both the referring practitioner and the adjuster. The IMC should strive to complete an assessment within 1 week of the referral. There's no expectation for treatment by the IMC. In fact, in most cases, it's not allowed. My goal would be not to take clients from a particular clinic or a particular practitioner. It's basically to help you to manage that client more effectively. If multidisciplinary care is required, you can be part of that multidisciplinary team. So basically, I will review all the relevant information regarding the injury that you can provide to me. I will examine the patient with reference to the diagnosis and treatment per the DPTR. I'll provide advice and a report about the diagnosis or the treatment of the patient. And I might recommend a further assessment or a multidisciplinary assessment of the injury or an aspect of the injury and the persons who should be included in that assessment. Some of the things that I would personally try to address for the physiotherapists is to preemptively discuss some of the difficult things that physiotherapists have with their patients and that we struggle to talk to them about. I would try to address the presence of abnormal perception of pain and dysfunction given the level of injury. I would try to talk about the normal stages of healing so that they have a framework for which they're expected to recover. I'll address the presence of psychosocial issues and try to delve a little bit into how that's affecting their perception of pain and recovery. Discuss hurt versus harm. Try to highlight the importance of attendance, not only in recovery, but how it's viewed by the insurance company if they're not attending regularly. And then talk about the whole concept of active rehabilitation, in that they need to be an active participant in their recovery, attending with regularity and following the advice of their medical professionals, but also active within the treatments in terms of exercise and compliance with the home exercise program. Finally, I might delve into whether or not there's an early lawyer relationship. Not that people don't need legal representation, but lawyers tend to have people focus on symptoms and dysfunction, where we as physiotherapists tend to want to have patients focus on how they're recovering and gaining function. Just helping the client understand that a lack of recovery is not an indication for further treatment, but an indication that treatment needs to change significantly or be discontinued. On the next slide, you see an example of an AB5 form. It's a pretty simple form to fill out. The practitioner that fills it out and makes the referral gets paid $50. I would like you to be as specific as possible about what you're seeking from the IMC assessment. Please try to include outcome measures and diagnostic imaging reports, as well as some brief notes about what kind of treatments you have done to date and your initial diagnosis and treatment plan. Some important things to remember about the IMC process is that no approval is required in protocol. However, it is best practice to communicate with the adjuster. Even if you didn't initially check off that you intended to refer within 3 weeks, but you start to develop a sense that there are some complicating factors and significant barriers to recovery that are going to reduce the client's prognosis for a successful outcome, you could make the IMC referral. You have to fill out the AB5, but you do not have to get pre-approval from the adjuster. As I said earlier, some adjusters might try to block this process, but you can refer them to the DPTR or to the Superintendent of Insurance, as I said. Ideally, the referral would be made around the 3-week mark following your assessment. This is not mandatory, but the idea is to try to get ahead of some of these complicated problems. I think most of us can think back to situations where we knew from the very first day of assessment that the patient was going to be a complex patient with a protracted recovery period. And definitely by the 3-week mark, we would have a strong sense that there's little or no recovery happening. Another reason to get on it early is, as we know, there's a lot of delays with incorporating other professionals and multidisciplinary assessments, and that stuff would also then have to be approved by the adjuster. So again, when you get on it early, it's already going to take potentially weeks or months before you can access some of these other multidisciplinary team members. A referral to an IMC can be made out of protocol as well. However, that would definitely require pre-authorization of the adjuster. And one final important note is the IMC appointment does not count as a visit or a unit within the protocol. So it's good practice on the AB2 report to try to mention that you intend to refer to an IMC if you're not seeing recovery. And it is a good idea to send a copy of the AB5 to the adjuster as well as to the IMC. So in my mind, it's a pretty slick process. You're getting paid $50 to make the referral. It's not taking anything away from you in terms of visits. It's getting your client access to an experienced practitioner for a second opinion so that we can make sure diagnosis and treatment is correct, as well as have a strong management plan. So I hope you agree with me that it is an excellent tool for our clients and really is a high level of medical care and intervention. And if we use it appropriately, it should take a lot of stress off us as a practitioner and help to ensure more successful outcomes from our profession of physiotherapy. In the rest of the presentation, you'll see a number of examples of outcome measures that can be very valuable. This is very specific to the motor vehicle insurance patient. However, I would also suggest that this can be a very appropriate tool for other private patients as well. If you have clients with yellow and orange flags, anxiety and depression type issues, the PHQ-9 and the GAD-7 are very helpful, as well as the Pain Disability Index. I try to also include, wherever possible, some of the interpretive guidelines so that you can see with certain scores where a client falls in terms of their prognosis. Don't worry, however, if you haven't implemented outcome measures other than maybe some numerical report of pain. This would be part of what I would try to delve into a little bit further during my examination to lend support to the fact that we are dealing with a client with a number of factors and an abnormal perception of pain and disability. So this basically concludes my discussion on the role of an IMC. So I want to put it out there that if you're struggling with clients who are making an incomplete recovery, or the issues seem to be beyond your training or experience, I would be more than happy to assess and provide a second opinion. With referral, there are a number of options. I would strive to provide you some feedback as to what I believe is going on following assessment so that you can learn from it. I would be happy if any practitioners wanted to attend an assessment with their client. And if you indicate on referral that you want to try to maintain treatment of the client, I would provide you with some advice as what I think treatment should look like. Or if you feel like you've reached the maximum recovery that you can provide to the client, I'm happy to take over the client. Or if you wish to co-treat, I believe we can also make those types of situations happen. I currently have 24 years of experience. I'm FCAMPed with advanced knowledge of biomechanics. I have extra training in concussion management, TMJ management, vestibular management. I've worked in multidisciplinary settings with high-level Olympic caliber athletes. I have years of private practice experience and also some vocational rehabilitation experience. I know that as physiotherapists, we're often scared to admit that we don't know what to do. However, I truly believe that most of us have the best interests of our clients' recovery in mind, and I'm more than happy to try to assist you with achieving this and help to make it a learning situation along the way, because I'm also very focused as well on the bigger picture and that our physiotherapy profession be perceived the way it should be. And we need to have strong outcomes that are evidence-informed in order to stay in the forefront the rehabilitation option in Canada. If you wish to make referral to me, you can do that through 360 Physiotherapy and Training and send a referral info@360-physio.ca. Thank you for your time. I hope you found this discussion enlightening and will be helpful in your practice and your client management. Have a great day.